Perhaps Mr. Ian Erdley from the Royal College of Surgeons has some answers. Do you think that it's fair to limit patients' access to surgery based upon things like their weight and whether they smoke or not?
Currently, about a third, or probably a few more, CCGs now have those restrictions. So from a geographical perspective, there are certain parts of the country where you can get a hip replacement with a BMI of 35, and there are other parts of the country where you cannot. That seems to us to be blatantly unfair.
Is there actually any evidence that patients who are overweight should not have hip or knee surgery?
All the evidence shows that patients who are overweight, at least outside extremes of weight, people who are overweight with a BMI of 30, 35, up to 40, get good results from hip and knee replacements. And indeed, NICE guidance says that access to such surgery should not be restricted to people below a certain weight. What impact do you think that this has on patients? I think there's two or three impacts. Firstly, patients who've got a painful condition, such as arthritis of the hip or arthritis of the knee, or who have restricted mobility because of that, will continue to suffer while they wait for treatment. They'll also continue to use healthcare resources. They'll still need to take painkillers, they may still need physiotherapy, and delaying it often almost increases the cost in the long term. Clearly, if they are of working age, then their productivity to society diminishes. They can't go to work or work in the same way for those people. So there are a number of consequences.
So the decision on whether a patient gets their surgery depends on where they live. A postcode lottery, some might say. And that's the same for Nina. If she'd lived a few miles down the road, she would have been cleared to get her knee replaced. It's a situation that makes husband Jeff angry.
If her knees are in such a state in Yorkshire, why should there be any difference in Nottinghamshire or any other county or any other city? Why should there be any difference? It's the same problem. You know, I mean, has one area got to save more money than the other? I don't know. If so, why?
The idea of rationing surgery is fast becoming one of the most controversial topics within the NHS. Last year, there was a 45% increase in the number of patients rejected in England after their GPs recommended them for surgery. And this year, a new proposal is currently suggesting a number of procedures could be deemed unnecessary. Dr. Graham Jackson is leading the consultation.
There's some conditions which NICE, which gives out guidance nationally, has suggested that shouldn't be done. For example, surgery, snoring, and we're saying that actually this is the kind of thing that actually is ineffective and can cause harm. Surgery is not without its risks. There's a general anaesthetic, there's a procedures we have done, infections afterwards. So actually, we were performing procedures on people which actually may make them more poorly in the short term without long-term benefit. It just doesn't make sense.
So the argument is that rationing certain surgeries is actually desirable for the patient, but it's also to benefit the NHS as a whole.
We know the NHS has got finite resources, so the money we have in the NHS we must spend most cost effectively. So if we stop doing some of these procedures, which we think can cause harm and have no clinical benefit, the money we've been spending, the resource we've been spending on those procedures can be recycled into more modern medicine and providing different services for the population.